Respected chairpersons and my dear friends, at the outset I thank the organizers and special thanks to Dr. Jairani and Dr. Kamraj for bringing me here. And I really congratulate for the wonderful arrangement and a meaningful Congress. Thank you. And we'll move on to the management of middle-aged women and sexual. And it just to recapitulate what is sexual health, I think you are all aware of this. And it is nothing but a state of physical, emotional, mental, and social well-being related to sexuality. And the definition also you're all aware, but the definition according to American psychiatry is limited to psychiatric disorder and does not include organic causes of sexual dysfunction. But according to the international classification, the various ways in which an individual is unable to participate in sexual relationship as he or she should wish. That is the definition of the female sexual dysfunction is a multidimensional, as already everyone has spoken about it, combining biological, psychological, interpersonal elements of multiple etiology. So coming to the middle-aged, it's very common among middle-aged people. And two important overlapping factors affecting the female sexual dysfunction is the aging and the menopause. And that is the time the comorbid condition also comes and make it complex. And it may not be reversible without therapy. And as the hormonal deficiency does not decrease over the age, the symptoms also can persist. So the sexual problem is particularly important during menopause transition because the hormone deficiency is ultimately the responsible, and the estrogen deficiency causes reduced vasocongestion, lubrication of the genitalia during sexual arousal, vaginal dryness, dyspareunia, a decline in testosterone, decreased libido, fatigue, and decreased sexual activity. So this is a simple bar diagram which shows the lower estrogen levels are associated with the increased prevalence of sexual problems in middle age. And I thought this is just to recapitulate so that a physician can understand how to treat them. And another thing about the female sexual response, everyone was talking about the intimacy, how it is included to have a sexual drive. And morning also they were discussed, the sexual depends upon the interaction between the mind and the body. Mind cannot direct to do this, so they have to have a control over the body also. Another molecule which says that a lot of biophysical female sexual response take into account, like interpersonal, psychosocial, physiological, biochemical. If we understand this module, it's very easy to treat the female sexual dysfunction. So many complex things interrelated. And again, the physiological and organic factors are tuned on. Then the excitement, the faster and greater sexual response is there. So this is just to know so that we can treat them appropriately. So the prevalence are there, nearly about 45. They are affected mostly related to the decreased level of estrogen, testosterone. They report new onset of low desire, poor lubricants, orgasmic difficulty, and only 12% of the women have both measurable dysfunction as well as distress. Usually the perimenopause and middle age, they don't associate this with the distress. But in menopause, 15% of them have a distress also with the dysfunction. So this and all everybody knows about the classification. So what happens in perimenopause? The sexual responsivity decreases, sexual frequency decreases, libido decreases, increase in vaginal dyspareunia, and ultimately they have a partner relationship. But usually all these problems overlap also. Another thing they say that in postmenopause and perimenopause, decline in sexual arousal, interest, and frequency of sexual activities because of the vaginal dryness. So there are other risk factors also play into midlife because they would have undergone some surgeries like hysterectomy or some other surgery in abdomen or in the vagina, and spending long hours at work and traveling without a spouse very often, and they're interested in career, and the comorbid conditions also play in. So these are all the risk factors associated with FSD. So anything we have to diagnose, like any other clinical condition, we have to take a proper history, but the best barrier is the communication. As a primary caretaker or a gynecologist, many of us are very busy with other things. We don't take proper history. The best way to find out is the questionnaire system. This will help quickly. We can assess there is a good screening tool. This will provide a pinpoint appropriate diagnosis whether it's a psychosocial problem or a physical problem, and we can manage appropriately. So that the quick questionnaire system is very good. And we have to do, like any other case, we have to do examination also. If she is having a surgical menopause, whether she has a atrophy in the vagina or she has a premature menopause. So we have to evaluate the vestibular pain, ability to retract the clitoral fold, and of course the abdomen and the pelvic examination. She may be having a endometriosis or a pelvic mass or a pelvic inflammatory disease. So we have to do a examination also quickly. So how do we manage? It has a pharmacological therapy that can be an hormone or an non-hormone, psychological therapy, non-pharmacological therapy, and surgical also we have. So now most important thing from morning we were talking is the counseling. The couple has to be counseled, and the next will be the sex therapy, which will be helpful in educating the patient about the normal sexual response, and it can help the couples to negotiate sexual expectation also. So this is very important, a simple remedy, lifestyle changes. The counseling, we have to tell them proper exercise. These IT people are so much stressed, and all youngsters, they are very anxious to go up the ladder very fast. So we have to tell them to reduce the stress by doing exercise or a yoga or meditation, of course a healthy diet. The overall this thing will be improved, and spending much time with your spouse, going out for a weekend, the other things is very important. And of course, even IT people have started drinking and smoking, so we should look into that also. So there is a place for physical therapy also whenever there is a dyspareunia, vaginism, sometimes pudendal nerve entrapment also. So the few drugs to mention is bupropion. There is a RCT done for premenopausal women with an hypoactive sexual desire. That 300 milligrams sustained release has got increased sexual pleasure, arousal, and orgasm. The next thing is bupropion. Usually it is associated with sexual dysfunction with SSR that can be given. And botulinum toxin we can increase when there is a vulvodynia, and Sedental they have elaborated. It increases the blood flow to genitalia as a positive effect on the arousal and orgasm premenopausal. So this is again, it was stretched from morning. We have to talk to them. The psychiatric services is very, very important. Even in midlife, they have all sorts of pressure at home and the workplace. So that can be the cause for sexual dysfunction. So the hormonal, which has been dealt in detail, and non-hormonal is flibberacin and melanotide and lubricants. The hormonal she has dealt in detail. It relieves vaginal dryness and also helps to discomfort with intercourse and some urinary symptoms. This perimenopause, they very often come with urinary symptoms. Invariably, urinary culture is negative. They require a small dose of vaginal estrogen cream. And see, that is very small dose. We need not worry about the side effects. The local application, we need not even combine with progesterone. Even the uterus is there, we need not combine. A small dose for shorter duration, it's always safe. Maybe every day for a week, then twice a week, and then we can review her after a month, then third month, and we can even stop it slowly. So another good drug, which is right now is not available, it has got a very good effect on sexual function, drive, interest, and performance. That is the tibolone, and the total score is also, when they compared, it is increased. So the androgen declines steeply in early reproductive age group, and postmenopausal ovary continues to produce androgen. As my previous speaker stressed on, don't touch the ovary. Please retain it for longer time, and all that you have to prevent ovarian tumor by doing a self-injectomy. So the transdermal testosterone is the commonest off-label use which is given for sexual dysfunction, but in perimenopause and late reproductive, it's better to combine with contraception because it has got an effect on the fetus. So the Libichel is already talked about, which will increase the sexual satisfaction, and it still remains as 4 million off-label prescriptions are given to the women for this Libichel. So this is also dealt in detail, but the current study is looking at the effect on the gynec and breast malignancy because of DHA vaginal ovule. So flubanazolone is actually mentioned by Madam, and it acts on centrally acting and increased dopamine and norepinephrine. It decreases the serotonin. The effect was accidentally discovered when it is used for the antidepressant. This causes increased desire, sexual arousal, decreased distress noted in lot of large phase trial. And one important thing we have, we cannot be used just like that. I think it should be used only by the certified people, and they should not take alcohol. It is written in the box. And contraindicated is when they are taking antifungal treatment also. Another thing, drug is also mentioned. It produces a drop. That is actually the trial, they have done it and they have dropped it, and they have restarted it again as a subcutaneous injection. So lastly, the device is also sometimes very helpful, the clitoral suction vacuum device, but no data to support it is advantage. The self-stimulated, it is inexpensive, and it's a good alternative to vacuum device. The dilators also, which has been mentioned when they have a little bit of vaginism. So the surgical option will be the vestibulectomy when they have a severe vestibule pain. It may be a localized vulvodynia. Sometimes it relieves that pain. And when they are obese, their self-esteem is less, and around perimenopause, because of that they have an abstinence. So this is an indirect psychological therapy, not a direct thing. To sum up, so we have to find out where is the fault, whether it is a disorder due to lifestyle manifestations. If she stays at the office for a long time, so lifestyle management we have to discuss. If it is a surgical menopause, and if it is due to hormone, we have to give them a hormone. If the underlying cause is the psychosocial, we have to counsel them regarding that. And dyspareunia can be due to so many other causes also. If there is a local infection, we have to treat. Hormone deficiency also can cause, and sometimes it can be a neuropathic. So that also, sometimes even a perimenopause or middle-aged people have a hypertonic pelvic floor. In that case, they have to have a relaxed pelvic floor physiotherapy. So the midlife and beyond represent significant risk factor for sexual dysfunction. It impacts the patient's quality of life. Non-pharmacological approaches should be used first, focusing on lifestyle and psychosocial therapy. Hormone therapy is proven and it is effective. Non-hormonal therapeutic options are also available, and it affects the woman more likely to be depressed, dissatisfied with the home life, dissatisfied with emotional and physical relationship with their sexual partner, and overall the health-related quality of life decreases. So we have to do some research. The area of research, all that we have to build the knowledge of the prevalence, predictions and outcome. And aging and menopause, which are unique to women, should be looked at closer to understand the hormonal process involved in female sexual dysfunction. And so the treatment strategy will be the sexual health education, and we have to assess the patient's goal. What is a real problem? And we have to target to it. And if there is a comorbid condition, we have to look into it. And it's always a team approach, and treatment should be highly individualized. So to conclude, So what looks impossible today is only a problem that needs a different approach than what has been tried so far. So no single therapeutic approach is appropriate for every woman with sexual dysfunction in midlife. And behind every problem are innumerable solutions, yet only an approach that encompasses the mind, body, spirit will bring about the most rewarding, fruitful outcomes. And similarly, understanding of women's sexual health problems starts with comprehensive evaluation of her sexual, medical, and psychosocial history. Sound science must be our pride in choosing which problems to tackle, how to approach. So the female sexual problem in midlife, the various modalities of treatment may be used simultaneously to achieve better sexual function, such as treating chronic disease, optimizing chronic medication dosage. Suppose she is on a psychotherapy, psychiatric treatment, we have to optimize that and supplementing with most appropriate hormonal or non-hormonal therapy. And thank you for patient listening.